I wanted to take this opportunity to again formally thank the both of you. It is a real pleasure to have you, Mr. Stefan, here with us today, talking about the evolution of national health insurance policies. As the attendees may know, Stefan is the Deputy Director, Health Systems Design at Bill and Melinda Gates Foundation. We also have with us Dr. Prem Pillai, who is a leading neurosurgeon and the Chief Medical Officer at Pure Land Group, and we would like to thank them as well for assisting with this session. And on that note, I will hand it over to both Mr. Stefan and Dr. Prem Pillai to really take this session forward and share these invaluable insights to wrap up Medical Festival Asia. Thank you again for your support, and thank you for everyone attending today's afternoon session to wrap up Medical Festival Asia. Dr. Prem, the floor is yours.
Thank you, Varun. It's Stefan, it's great having you with us. I know you are very deeply involved with health system design for the Bill and Melinda Gates Foundation. You were with the Rockefeller Foundation as well before that. I'm really interested to know your viewpoints on achieving universal healthcare, particularly in relation to spend, whether it's public spend and the GDP of a country.
Thank you, Prem. Okay, let me just start with that, and let's see where we kind of go with it. And please break in as I try to give a few, maybe a little bit of a fact base to start, and if that's helpful. So, you know, what I might call middle income Asia, okay, but including Southeast Asia and parts of South Asia now, are really at the kind of early stages of what we might call a health financing transition. So most of middle income Asia spends, I'd say, in the range of 3 to 6% of GDP on health. To give you a kind of a frame for that, in OECD countries, that's usually 6 to 12%, with, of course, the US off the charts at about 18 to 19%. So as countries get richer, they tend to devote more of their resources to health. To give some perspective on that, the lowest, perhaps not surprisingly, Bangladesh still spends only 2.3% of its total GDP on health. Vietnam, Nepal, and Cambodia all spend 5.5 to 6%, interestingly. And that was a little bit counterintuitive even for me. So, you know, but what we guess is that those spending rates, those aggregate rates, both public and private, will continue to go up. Health is a preferred good. So I guess there's a couple of questions here that kind of emerge. How much is spent in total, and how much of that is spent by government? These are big questions. You know, we're in a region where, frankly, in many cases, markets have outpaced state institutional capacity to regulate, understand, or guide them. I mean, that's what's very interesting. So, you know, in terms of spend per capita, and this is just using World Bank data to give you some perspective, not surprisingly, the wealthier middle-income countries spend the most. China spends $441 per capita as of 2 years ago. This is in straight non-purchasing power parity dollars, so the real spend might be a little bit higher. Malaysia spends $384. Thailand spends $247. At the other extreme, just to give you a sense, Bangladesh spends in total $36 per capita right now on health. Pakistan spends $45. And even India, where I'm sitting today, only spends about $70 per capita on health. That's everything. To give you some frame for that, South Korea spends over $3,000 per capita on health, and Japan spends over $4,000. So these are actually quite different numbers. But nonetheless, we expect the numbers in middle-income Asia to be going up pretty rapidly, you know, because of this transition. It's preferred good, rising middle class. But in this, and in terms of policy, there might be a couple of issues to just highlight. One is that it's the public share that I think really interests us here. So to give some kind of sense of this, one extreme is Thailand. So Thailand had a really, really quite deep structural reform, has, you know, true universal coverage. About 4 out of every $5 spent in Thailand are spent publicly, largely either by the Ministry of Health or through the 3 large national health insurance schemes. On the other hand, Bangladesh spends less than 1/5 publicly. Essentially, it's an unregulated, unmanaged system. And that public spend, to again give you an order of magnitude right now, is $7 per capita per year. It's almost nothing, right? Notwithstanding, Bangladesh actually gets reasonable outcomes because they have some very good public health efforts led by groups like BRAC. Much of ASEAN spends about half. That might be a good number. So Vietnam, Indonesia, and Malaysia are examples of countries that spend their total health spend is about half public, half government, and half private, okay? And then there are a sort of a second group that spends somewhere between 1/5 and 1/3 publicly. And that is really where they're trying to kind of, it's still an issue of state formation, deepening the tax, sort of the tax net. That might include Laos, Cambodia, Myanmar, the poorer parts of ASEAN, and even the Philippines, which has continually struggled with raising more dollars. So, and then the high spenders in terms of public spend per capita in the region are still Thailand and Malaysia. So Thailand spends $188 per year per person publicly, and Malaysia spends $194. But of course, they spend that in very different ways because of the nature of the system. So, and the other thing, just to signal, and I'll finish after this, and please follow up, is that the public share does have a relationship to out-of-pocket payment. And I mention that because that's politically a huge issue and often a driver of kind of efforts towards universal coverage. So to give you again a sense of that, the out-of-pocket payment rates so you have an extreme here. Thailand has an 11% out-of-pocket payment rate, lower than many OECD countries. Very equitable provision, very low out-of-pocket payment, and very high public provision. Bangladesh has a 76% out-of-pocket payment rate. So essentially, people are largely buying their health individually. The same in Myanmar, 74, and India is about 65. Okay, so you know there are early stage efforts. So many of the first stage, which I'll speak to next, but I'll pause now. National health insurance reforms do have a partial aim at addressing this really, really deep kind of financial protection or out-of-pocket issue because it's so politically salient. So let me pause there. That's helpful.
That's interesting because in Singapore we are, you know, we're a first world country in a second and third world region. I think our percentage of GDP that we spend on healthcare is around just about 5%, half of Canada's.
Right.
About around $2,000 on spend, and we have a universal healthcare system that is a combination of public and private care. It seems to work. If you look at all the indices in Singapore, it seems to work very well. You know, maternal mortality, infant mortality, lifespan at birth, they're all pretty high up. In fact, the question I think I want to ask you is that, does it always correlate to spend? If you look at the United States, the amount that's spent and the indices that are you know, generated, there's a discordance there, right? So what do you think about quality of healthcare per dollar spent? How do we, you know, look at that?
Yeah, well, that's going to be an issue and that's why we're talking about middle income Asia, because yes, absolutely. I mean, the US is, you know, the problem is whenever you kind of go to any sort of global meeting, everybody just passes over the US because it's such a bad example of how to design a health system, frankly, you know, for a variety of reasons. But, you know, there are ways that you can get good quality for relatively low spend per capita. And it's not one way, which is interesting. So I'll give you 2 extreme examples. You have a Singapore model, which is is a blended financing model, based on the ethic of both the country and the government. Personal responsibility is part of that storyline. Personal savings accounts, there's state support. They try to introduce a lot of market forces, and yet, as with other things in Singapore, this is under a very tight regulatory net in many respects, and a lot of transparency around spending. The other extreme, which was essentially a Big Bang reform, as you know, 20, 25 years ago, was when Bill Shao from Harvard worked with Taiwan to essentially redesign a system that had ended up being kind of like the US. Really scattered coverage, pretty high cost, good if you're a high-end doctor, bad for the population. And so Taiwan has very, very good financial protection, very, very good outcomes, a good public health system, okay primary care system. And I'm not sure what their public spend is, but it's probably not much more than Singapore's.
Yeah.
So they do very well. And that model is fundamentally different in terms of design than Singapore's. So there are a couple of ways to yes. I think what matters more is not the kind of, is there a normatively perfect blueprint, but how do you implement and how do you learn as you go? I think what's interesting about Taiwan and Singapore in particular, and I might add Thailand, I think in a slightly different way, is it's not so much the debate, in, especially in the global health world, is too much about normative blueprints. What's the best model or what's a better model? What seems to separate the winners from losers is much more the iterative learning and dickering, okay? Singapore is a great example for that. It constantly changes its formulas for purchasing, how much people have to put in, how the Medisave accounts, what is a poverty level. And that's a series of dickering in response to kind of signals they're getting from the system on a regular basis. So yeah, no relationship. The only thing that spend does have some relationship to, if you look at a list of 150 countries, is if you have very low public health spend overall or low government spend, you're probably going to get pretty high out of pocket.
Yeah.
That's a bit of an iron law.
So one of the other questions that's come up that we'd like your expertise on is, what are the politics around universal health coverage, and also coalitions that could emerge that could help with good quality universal health coverage?
Yeah, okay, it's a great question, because it's kind of the nexus between public policy and private actors. And frankly, in citizens. So if we go back about 8 years, the World Health Organization only passed its first, quote, universal health coverage resolution in December of 2012, okay? 90 countries co-sponsored. This was a big effort. In fact, I knew a number of people pushing this. And since then, about 100 countries have reached out to WHO asking for kind of, quote, technical assistance in achieving UHC. Now, of course, that's a global resolution. This is a vague notion, but the fact that 100 countries are reaching out shows that there's some degree of salience here. And, the guess is that for good and bad reasons, a lot of countries probably view UHC as good politics, okay? And I would add that if we think about ASEAN in particular, even before this, and I guess a little bit after, there were tentative steps being taken across the region to begin to try to offer greater access to services and some degree of financial protection to citizens. Remember, this was a region that 40 years ago was marked by what a colleague at Boston University called the aristocratic healthcare model. Good hospitals for the rich, and basically everybody else kind of figures it out. And that's clearly changed. So as an example, if we just go back 25 years, PhilHealth, the Philippines Health Corporation, was founded in 1995. So was VSS in Vietnam Social Security, basically the first step towards a more comprehensive kind of financial protection package. Health equity funds in a low-income country at the time, Cambodia, were piloted in 2000 and have since grown. and those were aimed at providing some degree of protection to the poor. Of course, the big kind of kahuna in the region, the Thai UC scheme, Universal Coverage Scheme, went live in 2002 and quickly raised coverage to about 99% of the population, and it's been implemented quite well. China kicked off its not the latest, but probably the most important and consequential round of really ambitious reforms around expanding coverage, reforming hospitals, and reforming procurement in 2009. And that's been built upon. They've also, by the way, invested quite a bit more public money in the system. And of course, most recently, which I think is very interesting given the size of the countries, you have the development of a single pool national health insurance model in Indonesia, JKN, which was kicked off in 2014, which brought together a whole bunch of very scattered and fragmented insurance schemes. And then, of course, in India, starting 2 years ago, you've had the rollout of the Ayushman Bharat scheme, which is only hospital-based, but aims to cover 40% of the population. So a couple of things that are interesting here. One is that the early system reforms, say in Europe and Japan, especially post-World War II, were probably driven quite a bit by national solidarity, right? The sense that we're all in this together, the social contract, you know? And, you know, I would suggest that arguably you could find some similar dynamics even in Singapore. However, what's interesting in a lot of middle-income Asia is that a lot of these are actually elite-driven reforms, which is intriguing, right? Why would elites do reforms that benefit others? Well, there probably are two elements here. One is what we might call political legitimization. There are states that are ideologically disposed to this, Vietnam and China being the most obvious ones that are run by single parties that, you know, base their legitimacy on providing some types of services to their citizens. And then there are, you know, efforts by both professional associations and political elites to kind of garner favor and some people do the right thing. So I think what many countries have found is that, you know, if you can blow these schemes out, it can actually be very good politics. It's a new vote bank. And, you know, I'd say that while the initial policy goal of schemes was to sort of improve access and financial protection, especially for poor people, they've had a lot of knock-on effects that impact on the larger health system. I'll just list a few quickly and then I'll pause again. So one is that, as we know, it's hard to take away things once you offer them, okay, right? Yeah. So, you know, I can give you an example from the United States, which is where I'm from. Well, you know, while there's a very rabid debate about the role of government and state not doing this and that, nobody from the Republican Party is arguing to take away Social Security or Medicare, okay? So national health insurance could be thought of as the thin edge of the wedge, gets you in there. And the most extreme version of this is in Thailand, where not only is most spending and provision public, but they've gone through, as you know, political chaos in the last decade, and yet the UC scheme is basically untouchable. There's a lock-in factor here. And spending has actually, in real terms, gone up quite consistently over time. Now, the other thing is it can create new budgetary pressures. So but government spending on health often mirrors economic growth rates. It's very hard to find money. What we've seen is some modest or even significant government reallocation, taking money out of some sectors and putting it into health. In the region, I think three probably most robust examples, and they're quite different countries. One is Thailand, because of the success of the UC scheme. The other, very interesting, because it was traditionally a very, very low public spender, is Indonesia. So that spend has gone up considerably in the last 2 decades in real terms, and they've taken money out of other sectors. And of course, the third is China. Which has also used not only massive growth, but has actually reallocated some budget to health I think real health spend has gone up by a factor of what, 20 in the last 4 decades. I mean, it's an incredible number.
Yeah.
Two other small points to make. One is that once you offer rights like this, and it's not a privilege, it becomes a right. You give somebody a card, it's a right. And this can create really strong efficiency pressures within a health system. So these can be allocative, that is to, for example, to spend more on primary care where you get more bang for the buck, or technical, that is spend more efficiently through a tighter strategic purchasing arrangements. So Thailand is probably, again, the poster child for having done both of these fairly effectively. I think many people on this have probably heard of ITAP, which is the Thai group that looks at priority setting, and has some fairly tense discussions with many pharmaceutical companies on a regular basis. So they're one of the best known priority setting groups in the region, and cost-effective analysis is now baked into benefit package design for Thai health insurance. Anything new that's expensive that gets put into Thai health insurance has to go through cost effectiveness. There's kind of an ICER ratio that they look at. And in the same way, what we're often seeing is that purchasing arrangements, which traditionally, for the last 1,000 years have been largely fee for service, are more and more moving towards the payment sort of package rates, diagnostic related group rates for inpatient care to drive efficiency, and more often towards some sort of capitated model for primary care where there's a single payment per person per head per year. So it's not a fee for service model. Now that's still in process. In fact, China is trying to roll out these changes right now, I think with some success, but of course deeply resisted often by the medical field, often for obvious reasons. And then this has a lot of significant implications for the private sector, but we can discuss.
Yeah, I think the coalition model, right? You need to get stakeholders on board, as you have pointed out, Stefan, which is not always the easiest thing to do. And I think that feeds into the next question is getting the private sector on board with UHC. Do they see it as a threat, or do they understand there are opportunities for them because there can be scale? So I want to know, what do you think?
Okay, so yeah, let me give you a few opportunities and a few threats, and then we can kind of wrap up and go any way you want or take some questions.
Yeah.
There are a lot of opportunities in this. So the most obvious opportunity is that in this region, we're going to see continued economic growth and a continued health financing transition, meaning that a lot of middle-income Asia will spend quite a bit more in the aggregate on health per capita in the future. No question about that. That's just kind of math, okay? It also will create demand not only for more health provision, but all the ancillary services related to it. Supply chains, pharmaceuticals, and for the upper end of the population, more private insurance.
Yeah.
Okay, so those markets are going to grow. Growing middle classes will be willing to pay more out of pocket or purchase fairly expensive private insurance to access faster, better quality care. And we actually have, frankly, a model for that already. I would add in both South and Southeast Asia, quote, unreformed systems that have reasonable public care, but a lot of people opt out, and that would be Malaysia and Sri Lanka, okay? So you can always go use the public system, but what happens is it tends to serve the poorer people, and then a lot of middle class and upper class opt out.
Yeah.
So, and that we may see more of that in the future. Let's see. I would say that the political pressures with national health insurance schemes in aging populations will create strong additional pressure to reallocate funds to health on the part of government. Okay, because old people vote. Okay. And I would mention that the public versus private debate, which has been kind of a corrosive and long-term debate, certainly in the global health field, I'd say it's almost dead. Most of the schemes that I've mentioned already purchase services from private providers. In Indonesia and India, for example, half of the purchasing is from private hospitals or primary care providers already. Okay. Growth areas like health tourism will almost certainly grow as OECD countries find ways to curb future spending. So they're probably going to be happy to start sending people to Southeast Asia for treatment more and more, and even pay for it because it's so much cheaper. And the other thing that would happen, which we've seen again more in OECD, but I'm sure we're going to start seeing more in Asia, is right now at the upper level, you do have like kind of health networks of hospitals. Like in India, you have Apollo, Fortis. You don't have that as much. You have pretty fragmented provision though at the middle levels. As you have more pooled purchasing, there's going to be a lot of pressure for private providers to network and consolidate. The earliest place we saw this was, or at least when we had a big transition in the US in 1965 when CMS, the Medicare and Medicaid program grew, you suddenly had this massive government purchaser and a provision network that time was mostly single providers has now virtually become all networked. It's almost impossible to survive as a single provider. Yes. I would expect we're going to see the same thing in Asia. Yeah. So it's either network and get big or die, frankly.
Yeah, yeah.
Or if you're in South Asia, stay very informal. But that, leads your ability to grow. Now, there are some threats, so I'll finish with those. As I mentioned at the start, markets have outpaced states during the rapid expansion in the last 40 years. I mean, I think an interesting analog for this is, with the exception of Singapore and perhaps Kuala Lumpur, in a lot of Southeast Asia, walk around a city and see how many parks you see. You don't see many, right? The markets are now providing parks. They're called malls. Okay. But you do see that in cities where states play a much stronger role in planning and development. So state capacity is still kind of growing, but it's middling, and there's going to be political pressure to improve this capacity. Now, that capacity could lead to stronger regulation of private providers and/or, as we've already seen in Thailand, tighter purchasing arrangements for private providers, lower sort of per case or per person payments, as that is funded through national health insurance. So Thailand's a good example. OECD model of very, very tight payment regime might be Japan, already exists. So, that could be part of the future. So efficiency is going to matter. There's also going to be strong political pressures to do more with less. And we've seen this in a few ways already. And I mentioned this earlier. There's going to be increased pressure for purchasers, insurers, even private ones possibly, to move away from fee-for-service, which most providers really like, towards DRG or capitation-based purchasing models, right? These tend to be more efficient. And there's going to be more rigor regarding what national health insurance will cover. I mentioned HITAP in Thailand. That's kind of, again, the canary in the coal mine. And stronger negotiation skills on the part of government with private suppliers for pharma or medical devices. Frankly, many governments are pretty amateur at this right now, but they may get better. The other threats that emerge is, yes, these schemes are getting bigger, but we all know, or at least many of the people on this call know, low or slow payments from national health insurance schemes are a kind of continued difficulty. I do know somebody who has a set of clinics in southern India, hasn't been paid in 2 years. I define that as a problem, right? The increased hassle factor of being formalized and subject to regulation, whether it's capricious or not. And in South Asia, that would be kind of weighed against the freedom of staying informal, where many providers still are informal in South Asia, but that means you don't grow. Formal means you stay in the dark. So let me stop there. Hopefully that was of some value, just to give kind of a sense of where this might be going.
No, I think that that was very useful. I think that the mantra of value-based care is now being echoed everywhere, and that resonates not only through public policy, but also through private healthcare. We have a question from Dr. Ravi Shirsa, and he wants to know, is it the remit of UHN for Gates Foundation and other bodies only for public health or private healthcare as well? And he says that this is where regulations will really benefit harmonization, pool purchase, like you mentioned, Stefan, and international boundaries.
Right.
And I'll stop there so that, you know, maybe you can comment on what he has said.
Yeah, so if I understand the question correctly, does the Gates Foundation think about private healthcare as much as public? Traditionally, definitely when the foundation started, it was very focused on kind of public provision and services. There is a small, you know, I would say insurgent group in the foundation that focuses quite a bit on the role of the private sector and markets. And I guess I'm affiliated with that group. So, you know, the mantra of the foundation is much more around, it's not about public versus private. It's about unified health systems that are delivering value for clients and for citizens. And as I said, the debate around whether a system should be delivered publicly, as in Thailand, or for that matter, Spain or Denmark, or privately, as in the case of, say, Japan or the US, is pretty immaterial, you know? More importantly is, are providers operating under a relatively coherent and fair both financing and regulatory regime? And can we see both value for money and quality of care coming out of that?
Yeah.
So that would be the bigger issue. So yes, the foundation is interested and definitely, in fact, in India, we're trying to spark quite a bit of work with Nat Health, one of the large health confederations, around how they can begin to work in a more productive way with government.
I have a question for you, Stefan. You know, when there are very big public health projects, right, there's unfortunately in many parts of the world this issue of corruption, which involves, as you know, politicians, business leaders. And at the Gates Foundation, I don't know, do you have some kind of systemic approach to mitigate this so the dollar gets to the consumer, you know, at the end of that chain?
Corruption. Okay, yeah. So that is, in terms of the health systems work, it's a difficult question for me to answer because we're not doing sort of direct projects where we give money to grantee X to deliver service Y. You know, we're much more kind of engaged at the policy, research, and design level,
Sure.
honestly. Remember that the Gates Foundation total spend in India might account for about 1/4 of India's
Sure.
health spend, okay? So in terms of like anti-corruption guidelines, yeah, we have a lot of them, right? I mean, that's by law. So but does that mean that we're doing, you know, do we have, for example, codes that deal with, we have codes that deal with what our grantees do, but that's very different than saying, for example, the foundation can address systemic corruption within a health system.
Yeah.
We know many systems. I mean, I think the unique thing about health around the world is that, and the tension we have is that it's both seen as a human right on one hand, and it's one of the most rapacious markets in the world on the other.
Yeah.
And those things coexist in kind of an uneasy way.
True. The other question I have for you is the role of technology. I mean, I'm a proponent of medical innovation and technology, right? And I know the Gates Foundation actually spends a lot of money on looking at new technologies, including in healthcare. So do you see that as something that can, you know, is there a mechanism that you look at to integrate it quickly so that you get more bang for that dollar you spend in public health?
Right. Yeah, I mean, I'll try to give an example from India for this, because this is actually one area where India might leapfrog, interestingly. you realize that, for example, even in Indonesia, with quite a really real success in many respects through its national health insurance program, a lot of providers are still sending paper-based data back up the system. So as part of what is called PMJ, which is the Hospital-Based National Insurance Program in India, they have now founded and are quickly developing a national digital health mission as sort of a corollary to this. And the goal is to do some of what you said, which is to actually dramatically do two things: lower the cost of understanding what providers are doing, and to some extent the quality, and to equip policymakers and other stakeholders with a lot more real-time information about what's working and what's not in the system. So when I think of technology, certainly in India, yeah, there's a lot of things like telemedicine, of course, and we think that'll only grow, and that's a global phenomenon. But to me, the integrated or interoperable data systems, I think one of the best examples in a low-income country in the world, yes, Thailand, by the way, has an amazing one. There's no Thai health insurance card anymore. They just use their national IDs. So the integrated card, that was, so they've gone a few steps ahead. But, what's interesting about technology is that the ability of a clinician or a doctor in Rwanda, anywhere in the country, to pull up any patient's full medical record, it way exceeds that of any clinician in the United States. Okay, so they've already got complete, electronic medical records for basically all Rwandan citizens. So yes, the potential there is huge, right? And they've also got some very interesting things like Babel, which is, a private sector group that does kind of e-consults, and then people can go and kind of get their pharma with a kind of a kind of virtual prescription from Babel and so on. So, we're finding lots of ways that technology can be an amplifier, but the only thing I would like to add is, and maybe I'm sounding like an old dog, is that technology alone is not a silver bullet. So if you introduce technology into a system where supply chains don't work, people don't come to work, where there's systemic corruption, it's still going to be deeply rate limiting. Yeah. So so it can be an amplifier. It can't be a substitute completely, at least in my opinion.
Yeah. Another question I have for you, right? In those countries which are high income, have implemented fairly successful UHC, I think one of their problems is the aging population, people 65 and above. And how are you going to pay for it looking forward? Let's say we project to 2050. Do you have any ideas about this, Stefan?
Not completely. I think the trends are concerning. So I was at a large universal coverage event in Tokyo a few years ago, and one of the former Keizo Takemi from Japan got up there and said, look, and he was being a little bit self-deprecating. He's like, we've got a bit of an issue here. He said, our debt to GDP ratio is now higher than it was at the end of World War II. Right? So we're borrowing for current consumption. Now in Japan, they might be able to pull it off because they're borrowing mostly from Japanese people, who put their money into these very low postal savings accounts. But that's not going to be true in the rest of the world. No, I think what's going to happen, which is why I mentioned medical tourism in Asia, is there is going to be increased pressure to do the things that you're seeing groups like NICE in the UK and HITAP in Thailand do, which is actually to define what benefits people are eligible for, because health you can consume, endlessly, right? There will be increased pressure on purchasing, I think. And there will be possibly more means testing, which you already have in Singapore, but many OECD countries do not, where you say, well, if you're above a certain threshold, if you make more than 60,000 US dollars a year, the state's going to play a much less kind of a much less intrusive role in providing financial protection for you, because we just can't do it between that and pensions, right? So, but I don't really know where that trend is going to go. I think, you know, we keep thinking we've reached the logical limit of how much health can cost, but keep in mind that in 1970, health was about 3 to 4% of GDP in the U.S. It's now 19. So you know, it's a huge drag on the economy, frankly.
Yeah.
You know, so we've seen reforms in the rest of the world, but I'm not sure if there's a top limit to this. You know, because societies are making decisions about how they want to use their money, and they're clearly saying they have a strong preference for consuming healthcare.
Yeah, very true.
Yeah.
So I think we're almost at the end of the session.
Okay.
Is there anything you'd like to say to conclude the session, Stefan?
No, I mean, the only thing I'd like to say is that I think it's you know, I think the having you know, first kind of arrived. I mean, I think I arrived in after graduate school in Vietnam in 1993, kind of looking for a job, and I ended up staying for 6 years. Nobody was talking about any of this.
Yeah.
So, you know, to me, it's fascinating to actually watch history happen. And I was wondering if you had any reflections on, you know, any large concerns or trends, and I'm sure there are many, that I haven't mentioned that you think are really important for the audience to hear.
I think we've covered quite a lot in this short while. It's quite amazing how much you have covered, Stefan.
Okay.
I think it's been pretty comprehensive without going into all the micro details.
Right. Okay. No, I think it's fascinating, and I think it's the only thing I would say is it's probably a conversation worth continuing, because, you know, I think the ability we can get, you know, getting the private sector to work with government in a productive way, we've seen around the world, is very, very challenging. And we can have a solution where 1 + 1 = 1, or we can have 1 + 1 = 3.
Yeah.
And you know, I think that this notion of treating this as a zero-sum game or a negative-sum game is probably the most dangerous trend that I see around the region.
I agree.
I think that's something that requires, this is what we're starting with Nat Health, and I hope other Southeast Asian associations begin to kind of focus on this.
Absolutely.
It cannot be a dialogue of the deaf.
Stefan, it's been a great fireside chat with you. I think all of us have learned a lot. On behalf of Global Health, which is running Medical Festival Asia, we'd like to thank you. We'd also like to have you back.
Okay.
You know, Global Health runs a lot of conferences in the region. It's very Asia-centric. We want to tap the best brains globally. It's been an honor and a privilege to have you with us. Thank you, Stefan.
It's been my privilege too. Thank you. This has been fascinating, and I look forward to coming back.
Thank you so much. Thank you, everyone, for being with us.
Take care.
Take care.